Okay, and good morning. We're going to go ahead and start now. Uh, I hope everybody can hear me. And we are going to be looking at the lymphatic system today, and then that'll lead us into the immune system, which we'll wrap up tomorrow. So let's go ahead and see if I can get this to open up. Here we go, lymphatic system. And okay, everybody should see the lymphatic system slide on here now. And so we'll go ahead and move forward. Hopefully this is all working. Okay. The lymphatic system is sort of, we don't really pay much attention to this really unless we get an infection. You go to your physician, your healthcare provider, and they're palpating your neck and say, oh, your glands are swollen. Oh, they're talking about your lymph nodes are swollen. They're swollen because they're fighting an infection. That's what we do very well. Now, that's about the only time we pay attention to our lymphatic system is when we become symptomatic. However, the lymphatic system is a very sophisticated process, a network. It's an organ, if you will. It has an organ system. It has vessels that are uh, very much like the circulatory system blood vessels. They run parallel to the blood vessels themselves. The lymphatic system's initial role is to collect plasma. It has left uh, the, the blood vessels. The circulatory system plasma has left the circulatory system. It becomes interstitial fluid. It is then captured by the lymphatic system and returned to the blood as plasma. So it goes plasma, interstitial fluid, lymphatic fluid, plasma. And before we return it, before it comes back to the blood as plasma, there's two large ducts near the subclavian veins where it enters. Uh, the, uh, the lymphatic fluid is filtered through our lymph nodes, because lymph nodes are where we have most of our white cells hanging out. The white cells, the T cells, and the B cells are in the lymph nodes, observing, watching, waiting for something, some sort of pathogen to come through, some sort of infected cell to come through so they can respond. And that's where they monitor our bodies. So, the term lymphatic vessels are the parallel circulatory system, if you will. The fluid itself is called lymph. It is interstitial fluid. It is plasma. It is filtrate. Whatever. It's all the same fluid. The Once we get into the lymph nodes, we are observing. We're looking for pathogens. This is where we can trigger our overall immune response, because we have a very sophisticated immune response we have, designed to respond to non-specific pathogens and specific types of pathogens. And the trigger takes place in our lymphatic system. So, functions of the lymphatic system. Well, interstitial fluid is recovered. It goes back to the plasma. Plasma is the link between all the systems. Remember that plasma is going to leak out of the vessels. It's going to become interstitial fluid. It's going to be recovered by the lymphatic vessels and returned back to the plasma. That's what it does. That's what happens here. We use the lymphatic system also to collect fat. fats in our diet, lining the simple columnar cells of the small intestine. You know that we have fenestrated capillaries that provide the blood supply to these simple columnar cells. And we have 20 feet of simple columnar cells. Well, in addition to the fenestrated capillaries, we also have lymphatic vessels here, which will capture the fat. The fat, when we eat fat, it's broken apart into glycerol and fatty acids. It's moved across these simple columnar cells where it's captured by these vessels known as lacteals. And these lacteals then are going to, the glycerol and fatty acids come through the lacteals, and then they are reassembled again as triglycerides in our blood. Vitamins come in the same way through our lacteals. And one of the most important roles that the lymphatic system has, if that wasn't enough, it wasn't enough collecting plasma, collecting interstitial fluid, collecting lymphatic fluid, returning it all back to the plasma. If it wasn't enough doing that, or picking up fats and vitamins, it can trigger our overall immune response, because the immune system depends on recognizing foreign pathogens, either ones we've experienced before, which we have antibodies for, or new pathogens. And so we can either destroy the pathogen or we can produce antibodies to target the pathogen. We have uh, T cells, T lymphocytes, uh, the T because they matured in the thymus gland. These T lymphocytes are going to be able to kill cells. They're the only cells that we have that can actually kill infected uh, cells of our body. Okay, now, so getting a little more detailed here, it is the amount of fluid that leaks out of the capillaries, the plasma that leaks out. Most of it gets recovered. 85% gets recovered. 15% is going to be interstitial fluid. We don't want to keep that interstitial fluid there permanently. It accumulates. Um, yes, we recover the plasma that leaks out right away, but the interstitial fluid, it isn't as simple as plasma to interstitial fluid to lymph to plasma. Most of the plasma is recovered. The 15% that isn't recovered becomes interstitial fluid. We can't leave that interstitial fluid there forever. If it stays there, it'll accumulate and start compressing. It'll start swelling. It will start developing edema. It will destroy the tissues. So this is where this actual only the 15% that is left behind is where the lymphatic system comes into play. The lymphatic system will recover that 15%, and then that will return that 15% back to the plasma. Now, lymph is water. It is the same water that we would have in plasma. It has water, it has sodium, it has proteins, it has vitamins, it has amino acids floating through it. It has glucose in it. So it's about 90% water and 10% some sort of solute. Lots of proteins in there. The lymph will come from plasma and it will come from the cells. So how much are we talking about? Well, actually about 4 liters a day of plasma is recovered as interstitial fluid. So we're losing a lot. Well, think about it. when we run um, through our kidneys every day, we're filtering 180 liters of fluid. We don't really have 180 liters of fluid. We have 8 liters of fluid. So we are here. We're running about 4 liters a day of fluid that has come out as plasma, um, and now it's interstitial fluid, and we get to return that 15%. Okay. Now, fat absorption. So, okay, so let me back up here before, Um, so the lymphatic fluid, it becomes interstitial fluid. It actually only amounts to about 15% of the plasma that leaks out. The other plasma is recovered. But that 15% is very important because that is the interstitial fluid that surrounds the cells. Now, why is this important? Well, obviously we're dealing with water and salt concentrations. We talked about that in fluid and electrolytes. And depending on how much water is around the cell, it can either cause a dehydration or hypotonic hydration, where you have too much water. So that's very important too. So, but the other thing is that these fluids around the cells, this interstitial fluid, if the cell is infected, if there's a pathogen present, the pathogen will eventually end up in the interstitial fluid. And so, in addition to maintaining our fluid levels, you know, um, water outside the cell versus water inside the cell, and our salt concentrations, we're going to be capturing these pathogens. So this is a very important. This is the other major role here the third role of this fluid. Yes, fluid balance is very important. Uh, We need to move water from our plasma to the interstitial fluid, and that water is going to help to regulate salt concentration in the interstitial fluid, which will indirectly regulate the water concentration inside a cell. Because, if you have too much water in the interstitial fluid, it'll dilute sodium. That'll cause, if you have too much water in the interstitial fluid and dilute your sodium, water's going to move into the cell and the cell's going to swell up. On the other hand, if your patient's dehydrated, they have less water in the interstitial fluid, which means it's going to appear to be more sodium. It's going to draw water out of the cells, and the cells are going to shrink. So you have, the um, the interstitial fluid is really important then in maintaining a nice balance between outside the cell and inside the cells. Think back to dehydration and overhydration, or hypotonic hydration, from fluid and electrolytes. So now what about fat? Totally shifting gears here. There are lacteals. Lacteals run right beside the capillaries in the basement layer of the simple columnar cells lining the small intestine. And fats can't go through the capillaries, through the blood capillaries, but they can be absorbed by the lacteals after they're broken apart by bile. So when we eat fat, we release bile salts from the liver stored in the gallbladder. We release those into the duodenum, and that essentially chops the fat up. It's sort of almost like a detergent to grease or a fat. And so it chops it up into smaller particles, separating the triglycerides and the glycerol, which then can be absorbed uh, as the uh, through the lacteal. We use the term chyle here. This is lymphatic fluid that is forming inside the lacteal. It looks almost like skim milk because it has a very high fat content in here. So it's sort of a chalky, milky looking appearance, this fluid, as it's being absorbed. Now, our lymphatic fluid, it isn't enough for us to be collecting pathogens uh, in the interstitial fluid. We run our blood, uh, our circulatory system goes through the spleen. The spleen is monitoring for pathogens. The spleen is probably our largest true lymphatic organ. We run our lymphatic fluid through our lymph nodes, which are packed full of white cells looking for pathogens. So our spleen is monitoring, and the lymph nodes are monitoring. They're looking for pathogenic organisms, bacteria, viruses, funguses that don't belong there. They're looking for infected cells that don't belong there. And so the T cells, the lymphocytes, will destroy pathogens. They will destroy the bacteria. They'll destroy the virus. They'll destroy the fungus. They'll destroy infected cells. And this is all part of our defensive mechanisms here. So, so this is our lymphatic system. So I've sort of if I've beaten that into the ground a little bit about its three roles, I apologize, but I can't emphasize it enough. Now, we have this parallel circulatory system that, as I say, it runs right beside our veins. It's a low pressure system. There are series of lymph nodes to filter our lymph. Located in different parts of our body. We have the cervical lymph nodes in our neck. That's when those are the ones that you get referred to as, oh, your glands are swollen. When you're fighting an infection. It's not unusual to see a bulge in, or it feels swollen or like a bulge there. Sometimes the lymph nodes, particularly in children, can become so swollen that they bulge out on the surface of the skin or underneath the surface. We have lymph nodes in the axillary region. We talked about those with breast cancer. That's like the first place that cancer cells will migrate to or metastasize to is going to be the lymph node, the axillary lymph nodes. We have lymph nodes in the inguinal region, around the area, just about the level of our belly button. So we have, a vast collection of these nodes in different parts of our body. Now, all of these capillaries, these lymphatic capillaries that are present here are feeding into uh, lymphatic vessels, for what a better term, a lymphatic vein, that is going to collect our interstitial fluid and run it through these lymph nodes to filter it, to to monitor. It doesn't filter anything out in the sense like the glomerulus does. It's designed because it's all low pressure. What it's designed to do is allow the lymph, T cells and B cells to look for a pathogen or an infected cell. That's the filtration effect. The vessels, lymphatic capillaries become lymphatic veins, which become larger veins. And there are two ducts that dump we'll call it the filtered lymph back into the blood. We have here at the right and left subclavian veins. Remember, the subclavian veins are directly underneath the clavicle. That's why they call them subclavian. There is a duct. There is the right thoracic duct, and there is the thoracic duct. The right thoracic duct goes into the right subclavian vein, and the thoracic duct goes into the left subclavian vein, and that's where our lymph is returned back to our plasma. So it just makes a big circuit. It uses the same principles as our veins. We use skeletal muscle contraction to push the lymph against the forces of gravity. We use pressure changes, just like, when our diaphragm drops and our lungs expand, that's going to help squeeze lymphatic fluid up uh, towards the thoracic ducts, just like we use the pressure changes in breathing to move blood up the vena cava. We have valves in the lymph to do the same thing. They prevent backflow like they do in the veins. We also depend on arteries. The arteries are running right beside the lymphatic vessels, and the arteries, of course, are going to pulse. Every time a surge of blood goes through, the wall will expand, it will snap back, it'll expand and snap back. And that action, if there's a lymphatic vessel right beside it, is going to help push the lymph up towards the duct. And the lymphatic vessels also have their own smooth muscle lining, which will contract. So they're going to squeeze themselves to move lymph forward. And just like in our blood supply, the more active we are, the more lymph we're going to be returning back to the blood. One of the things we pay attention to is if a person has an injury, we immobilize the injury. Now, this is because the more active we are, the more vascular lymph comes through. But uh, if we immobilize the injury, it slows down the return. That keeps as we say, the inflammatory process. The inflammatory process is a healing process. With the inflammatory process, we release histamine. Our blood vessels dilate. They become more permeable, and we carry more oxygen and more white cells to fight infections. And so the inflammatory process, the redness around an injury, is a good thing. We allow more fluid into the tissues, which we have to recover because we're leakier and more permeable. Well, this we have to immobilize or at least restrict motion of a part of the body part that's injured to allow the lymph to stay there a little longer, because that lymph is actually helping to carry, white cells. It's, it is interstitial fluid carrying glucose and oxygen being released from the blood itself. And so we want to, give the healing properties of the components of the lymph. The lymph itself is just water, but it's carrying, the proteins. It's carrying the white cells because white cells like to swim in something. It's promoting healing. So that's one of the reasons why we immobilize an injury. So now this is what it looks like inside a lymph vessel with an artery right beside it. You can't see the artery, but you can see the effects of the lymph moving. Notice how the lymph is moving. Every time the artery contracts, every time there's a pulse, the lymphatic fluid adjacent in the vessel adjacent to the artery is going to move. And so this is something we don't see in the blood circulatory system. We see this in our lymphatic fluid. So something else we see is that our vessels, lymphatic vessels, work only in one direction. Now, capillaries have blood coming in from the arterial side and leaving from the venous side. Well, capillaries in the lymphatic system are different. The capillaries are closed end. They have one-way valves. And so fluid comes in to a lymphatic capillary, and it can't come back out. It can only go one direction. It can only move forward through the capillary. The valve opens up and and interstitial fluid comes in and becomes lymph, and it can't come back out. And then these capillaries then combine to larger and larger vessels, which then lead to the ducts themselves that dump back into the circulatory system. So, so we have capillaries. The lymphatic capillaries um, are present almost everywhere. We don't have them in our bones or our teeth or bone marrow. We don't have they're not present in the central nervous system. These capillaries are much more permeable than a blood capillary. They do have openings, but unlike a blood capillary, these openings are one way. Now, these openings are also very large. We can allow more things to come into the lymphatic capillary. It's big enough for large proteins, whereas a blood vessel keeps the large proteins inside. Uh, the this is ideal because when we are monitoring our lymphatic fluid for pathogens, by having these large openings that will let more material come in, we can detect infections. We can detect the presence of debris from a cell that's broken apart. We can detect cancer cells this way. We can detect pathogens, viruses and bacteria, maybe very large. And so they're going to pass into the lymphatic capillaries, which will then give us a chance to see them. Now, the downside of all this is that we may not be able to catch everything. An ideal system catches everything and destroys it or immobilizes it. But the lymphatic system is also a very good pathway for infection to spread. Because after all, we talk about the lymph nodes, the axillary lymph nodes with breast cancer. Breast cancer cells metastasize, they spread. The first place they show up is going to be in the axillary lymph nodes, and from there they can metastasize to the lungs, to the bone, to the brain, because it gives them a route to pass through. So, and that's the downside of this. Cancer cells will take advantage of our own system. And so this is simply to show you the relationship. The green vessels are lymphatic capillaries. Notice how here on the right-hand side, they are running parallel and around the regular capillaries, the arterial and venule capillaries in the regular capillary bed. So we have our own um, lymphatic, essentially almost a lymphatic capillary bed surrounding the blood capillary bed, so that as fluid is leaking out, we can recover it. Now, lymphatic capillaries, so this is a highly detailed technical animation here, but this shows you, it gives you the idea of what's really happening. There are valves, mini valves, in these lymphatic capillaries that will allow interstitial fluid to leak in and bring anything else along, because these are large openings. And the more fluid we have, the more fluid and the more interstitial fluid we have, the more that we're going to recover. And so these valves only open one way. When the fluid comes in, it can't get back out. And so once it's in these, and remember, these are closed end capillaries. They only go one direction. And so once they go in, then the fluid has to move back eventually to the ducts leading into the blood. And this is what they look like. You know, this is the valve right there. The cells that make up the lymphatic vessels. The valve is simply made of one of a cell, sort of laying over top of another cell, and that gives you your one-way valve. And they, you know, the way they're designed is the fluid can only go one direction. I mentioned inflammation, the inflammatory response earlier, and we'll talk more about that when we get into the non-specific immune system tomorrow. But typically, um, the inflammation is a healing process. When we are exposed to, when we have an injury, or exposed to a pathogen, for example, uh, our cells are going to release histamine. Histamine is going to trigger the inflammatory response. Uh, the basophils are very good at releasing histamine and triggering this response. The histamine immediately causes the cells to causes the capillaries uh, and the actually it causes the capillaries to widen and the arterioles to vasodilate locally. You get a local increase in a diameter of the vessel. They become more permeable, meaning the capillaries can allow more fluid to leak out here. And so we're sending more plasma out into the interstitial spaces. So a person, and so we're increasing blood flow because we're vasodilating and we are becoming leaky. So what'll happen is an area that's inflamed will look red. And many of us, if you look at your hands and arms, and you see a cut or a scratch or a nick, or you've been playing with your dog and somebody got a little too enthusiastic and you have a cut or a scratch on your hand and there's redness around the cut, that's a good sign. The redness is the inflammatory response. The redness is caused by uh, an increased permeability of the vessels there to blood flow. So we have vasodilated these vessels. We are making them more permeable, carrying more fluid into the interstitial spaces. Uh, this allows the white cells a mechanism to travel because white cells like to travel through diapedesis into the areas of infected tissues. So we bring in white cells. So now we have redness and we have increased plasma to bring in white cells. Now that may cause swelling because we're putting more fluid into the localized tissue. Tissue doesn't like to have extra fluid there, and you can't compress fluid, so it may press on pain receptors. So you may get some pain. So you've got redness, you've got pain, you've got swelling. You may have heat there. You may feel warm because you're bringing in more red cells, more blood. Um, and you have redness and swelling and heat and pain and healing because all of this is going on to increase the blood flow here thanks to the histamine. The histamine will trigger this reaction. And so you increase blood flow, you increase fluid loss into the tissues to give our white cells a mechanism to fight infection. You're bringing in more glucose. You're taking away more waste products. You're bringing in macrophages like the monocytes to help destroy dead tissue, to remove dead tissue. But you're bringing in T cells to help destroy infections. So over the inflammatory response is going to allow us to circulate more debris and circulate the pathogens so the T cells and B cells can spot them. Even cancer cells. Everything that's getting released from a site of an injury or an infected cell is ultimately going to be going through the lymph nodes, where the bulk of our T cells and B cells are hanging out. Now at a site of an infection, you're going to be producing neutrophils. Neutrophils are going to flood in. Neutrophils, are going to kill bacteria. They're going to attack viruses. You're going to be bringing in monocytes. Monocytes are big macrophages. They're going to be, you know, um, um, taking out damaged tissue. So you're killing bacteria, you're destroying viruses, you're taking out damaged tissue. Um, Basophils are releasing the histamine to help trigger this process. And then anything that gets through is from that localized process will go into the lymph nodes where the T cells and B cells are waiting. They tend to hang out in the lymph nodes, and they're going to be looking at the debris that's in the interstitial fluid that got through. They're going to be looking for viruses. They're going to be looking for bacteria. They're going to be looking for infected cells. They're going to be looking for cancer cells. And then that will trigger their response. So what the lymphatic fluid is then designed to present these pathogens. And once they get, then once the lymphatic fluid goes through the lymph nodes, it's going to be about as clean as they can make it. Now, to shift gears a little bit here, about the inflammatory response, now we're going to go to something different. We're going to look at what a lacteal looks like. This is a lacteal inside a capillary network surrounded, on the underside of a simple columnar cell. So here's our simple columnar cells here. This is the villi that project out from the simple columnar, or the villi form on the surface, the fingers that stick out on the simple columnar cell. And of course, we have the microvilli that are even smaller. These cells are one cell layer thick, so we have great absorption through the cell layer. Now, the nutrients, the carbohydrates, and the amino acids are going to pass through the blood capillaries, but the lacteal here that comes up, the lacteal, and it is a once, it only has, it's not, it has a closed end here, is going to absorb the fatty acids and the glycerol, because we chop up, the bile breaks the triglyceride down into the two components of a triglyceride, the fatty acids and the glycerol. That goes into the lacteal, and then we reassemble that after we get into the back into the blood supply. So, and it looks something like this. This is you see the lacteal there in the middle of the this is a villi right here of a simple columnar cell. And we see the blood capillary. We have arterial blood coming in and venous blood going out in the capillary network there. But the lacteal is in the middle. The lacteal is closed end, and what will happen is all of our triglycerides are broken apart and absorbed into the lacteal. So, and then that is returned, both the, both the all of the interstitial, the lymphatic fluid with the glycerol and fatty acids are going to be returned to the blood through the one of the ducts, the thoracic duct, or the right thoracic duct. Okay. And I can't emphasize enough just how extensive the lymphatic system is. It covers our body. It is a parallel circulatory system. The vessels mimic veins and capillaries. Same three layers as a vein. However, these veins and capillaries, of course, the capillaries are closed in, have a closed end. The veins themselves are thinner, and they branch more frequently because they're trying to collect this interstitial fluid from everywhere. They build constantly from a smaller capillary to a larger lymphatic venule, to a lymphatic vein, to a very large vessel, all still running parallel to our circulatory system. And they use valves much like the veins do. that as we, not only do we have the one-way valve going in, but we have a one-way series of one-way valves in the lymphatic vessels, looking very much like uh, the valves, the William Harvey's valves that he found, um, that we used to keep the blood from sliding back down in the veins. We have a very similar structure inside the lymphatic vessels. Lymph is pushed up and it drops back and closes the valve so that it can't retreat back down into the lower tissue. So, and this is what our valves look like in a lymphatic vessel. Uh, when when the vessel is contracted, from skeletal muscle or from respiration, or even the arteries alongside, or even the smooth muscle lining the vessel, this valve will open and shut to allow lymphatic fluid to go one direction, and then it'll close so it won't drop back. So we do this over and over again, essentially milking the fluid, up to the ultimately to the two ducts. The vessels themselves ultimately, all the lymphatic vessels are ultimately aimed to the these large vessels called the lymphatic trunks. Um, and we see the trunks here are going to, we collect, the largest vessels come together to form the trunks. And ultimately, the goal is to dump into the ducts, the right lymphatic duct and the left, and the right lymphatic duct and the thoracic duct. But, they're both coming into the subclavian veins, left subclavian vein and the right subclavian vein. So the right lymphatic duct is going to drain our right arm and our head and the upper right portion of our thoracic cavity. Let me go back, and this one doesn't, the previous one shows you this area highlighted in light blue. The right lymphatic duct is covering this area, the right side of our head, the right side of the thoracic cavity, and the right arm. The left side does everything else. And so the duct is at the junction of the jugular and subclavian veins on each side. Because you know that the jugular veins are coming down from the head, the subclavian veins are coming in from the axillary vein. It runs underneath the clavicle, and so the junction site of the subclavian vein and the jugular vein is where the ducts are. So, problems: lymphedema, localized retention of fluids. If you have a blockage in any of these ducts, in the lymphatic vessels, the fluid will be retained. It won't be returned to the blood. Fluid has to go somewhere. Fluid will find a home. Now, water can't be compressed. So the more fluid you put into an area without taking it out, it's going to cause rather dramatic edema, swelling. Here we see a a right and left arm. The left arm is not swollen. The left arm is significantly swollen. Look at on the right hand side of the picture at the bottom. You see immense swelling in the left leg and partial swelling in the right leg. So we have this retention of fluid is not unusual. If we have, that's an indicator that something is blocking the lymphatic return flow. It is, as we say, a severe localized edema. It's not systemic. It indicates there's a blockage somewhere upstream of where the swelling is located. So other examples here of lymphedema, you see the picture on the left. You see the patient has swelling in their right leg, and then on this is the same patient after uh, they've had whatever was wrong with him has been corrected, and you see that the right leg is still a little larger than the left leg, but the swelling has reduced because the lymphatic fluid is now being able to be processed again over. And here we see lymphedema, a different patient, uh, right leg swollen significantly here in both the around the femur and around the tibia. And there's some swelling taking place over here on the left leg. I'm sorry, this is the left leg, that's the right leg. Um, this is, this is post-treatment. Swelling is significantly reduced on the left leg and also on the right leg. The right leg looks better than it did, but it's still, you still have a lot of edema retention taking place here. And here's a forearm. This is the this is the left arm. Notice the swelling in here simply because we are retaining fluid. This isn't like a temporary swelling from an injury where you have you have an injury and it swells up and then it goes down. This is significant retention of fluid. So that's the kind of thing that can go wrong with your patient with the lymphatic system. You block the lymphatic vessel. Fluid is still coming out of the capillaries in the blood supply. 15% of that becomes interstitial fluid. If we don't recover that, it's going to retain, and you're going to start seeing this edema, this swelling takes place. Temporary swelling, temporary edema is part of the healing process, at the site of an injury. But this is a long-term edema where you're seeing a limb, an arm, or a leg, quadruple in size. Now the cells involved in the lymphatic system, they are cells that are going to be part of the immune system, the white blood cells, and particularly the T cells and the B cells. And of course, you're going to have the cells that form the structure of the system itself. Now, the immune system cells are the lymphocytes, the T lymphocytes and the B lymphocytes. These are part of what we call our active response. This is our secondary response or system. This is our, the specific response. We have two types of immunity. We have non-specific, which is a general response to pathogens, and the specific response, where we are targeting we target a unique pathogen. You've had a vaccine against hepatitis B, and so you mount an immune response to hepatitis B every time you're exposed to that pathogen. That is a specific response. A non-specific response would be, you release histamine because when you have a cut or a scratch to promote healing. We do that every time. That is a non-specific response. Inflammation, well, it doesn't matter what the pathogen is, it's going to respond. So our immune system deals with, in the lymphatic system, our immune system cells are dealing with a specific response. These T cells, these lymphocytes, these T cells and B cells are going to be focusing on known pathogens that we've been exposed to. The T cells and B cells are going to recognize our foreign invaders, for want of a better term, because they have antigens that are foreign. An antigen is the protein, a sugar-coated protein structure. It is the identifier. It is all of our cells have antigens as the self-identifier, saying this is us, and that's great, so that we don't attack ourselves, so we don't have an ongoing autoimmune disorder. The antigen is the marker. what our immune system looks for, and what the T cells and B cells are protecting against, are foreign antigens that don't belong there. Antigens that are identifying a bacteria or a virus as, you know, it may be harmless, but it's still foreign. It doesn't belong in our system. So we have the antigens are the identifiers. The T cells and B cells will detect those, will detect these foreign cells based on the foreign antigens. And of course, sometimes when our body goes, um, uh, when our cells aren't working, our immune system isn't working properly, sometimes we will identify our own cells as foreign, because we'll look at our own antigens and say, well, that's foreign. That's not us. And that's the whole basis of an autoimmune disorder. So what are we looking for? Well, with our T cells and B cells, we're going to be looking for bacteria. Bacteria will have antigens there that identify it as bacteria. It's a foreign antigen. Chemical toxins like the diphtheria toxin, for example, or other chemicals that are dangerous to us. A toxin is a poison, perhaps produced by the bacteria, or a poison that has entered our system. Maybe bee venom, for example. Bee venom is toxic to some people, and cause a fatal reaction. The viruses, the protein code of a virus contains foreign antigens. Red cells that aren't ours. If you're type A blood and you're given a bag of B blood by accident, the antigens on the B cells are going to trigger a response, because they're going to be perceived as foreign. And of course, cancer cells. Cancer cells will have foreign antigens, but the problem with cancer cells is that they change the structure of their antigen every 14 days or so. And that's just about the time it takes for us to identify it and produce a response to a cancer cell. And so what ends up is that cancer cells can avoid an immune response in many cases simply by changing their marker. Because every time we see a brand new marker, our T cells, our B cells have to respond to that marker, and it takes them about 10 days to 2 weeks to create a response. That's the way they work. But in that same time period, while they're creating a response to that cancer cell, the cancer cell, excuse me, is working to change its own antigen. So just about the time the B cell has produced antibodies to attack the cancer cell has, we've changed our antigens. It's not us anymore. So the T cells, what do the T cells do? Well, they are the only cells that will kill other cells in our body. T cells are going to attack and destroy infected cells. They're going to destroy bacteria. They're going to destroy viruses. Um, that's what they do. But they're the only ones that will kill infected cells. None of the other white cells will do that. B cells produce what are known as plasma cells. Now, when B cells are exposed to a pathogen, they will produce plasma cells, which produce antibodies, lots and lots of antibodies. And if we've seen this pathogen before, then we're going to produce antibodies very, very quickly. And what the antibodies do is the antibody will glom onto, I like the term glom, it will glom onto the antigen and block its action. It will either target the infected cell for destruction, or it will block the antigen so it can't do what it does. The cell's action, the bacteria's action, the virus's action is blocked, because we've landed on the antibodies have landed on the cell or virus or bacteria, and are preventing it from becoming more pathogenic, and that starts the process of healing. When we are infected by a new pathogen, it perhaps the flu, influenza virus, and we haven't been exposed to it before, we didn't get uh, a flu shot, our bodies will produce antibodies, and while you're busy producing antibodies, we're going to be symptomatic. You'll be symptomatic. You'll have all the signs of a infection, cold, sore throat, congestion, headache, body ache, fever, cough, all the fun things of the flu, nausea, vomiting. Can't forget that. And then you're going to start getting better after about a week of that. You'll gradually get better each day as your uh, B lymphocytes are producing more antibodies to immobilize that virus so it can't infect any more cells. And we immobilize the virus, and then we start killing all the T cells, start killing off the infected cells, and you get better. Not only that, but your body retains a memory of that particular antigen so that the next time you're exposed to that antigen that was on the virus, you don't take 10 days or 2 weeks to recover. You take you're never symptomatic because instead of taking 10 days to produce a massive response of antibodies, you produce antibodies in hours. So, because I mean, if you think about it, you have the flu and you get better, and then you don't get the flu again, assuming it's the same type of flu. You go out and live your life and go out to the store and go to school and go to work, and you're exposed to that virus again and again and again. But every time you're exposed to the virus, you have this massive surge of those antibodies for that virus that immobilize it. So you never become symptomatic. That's the whole basis of a vaccine. A vaccine will trigger the production of antibodies without having to go through all the unpleasant side effects of being, symptomatic with a headache, fever, pain, nausea, vomiting, whatever. So the T cells will kill the infected cells. It will destroy pathogens. The B cells will target infected cells for destruction. It will block the action of the foreign pathogen. So so the T cells and B cells are the major role here, the major cells in protecting us from infection. We get a response. We destroy cells. We destroy bacteria. We target cells that are infected for destruction. We target bacteria and viruses for destruction. We also use macrophages. Macrophages, the monocytes, are going to help destroy. You've got dead cells. You got cell debris. The monocytes will engulf that and will eat it and remove it from the system. We have what are known as dendritic cells, will capture foreign antigens and bring them to the lymph nodes to alert the T cells and B cells. Hey, we got a foreign antigen here. We need to prepare for it. So the immune system cells. This is what our lymphatic system does. In addition to bringing all the fluid back, I mean, that's very important. We know that. But the other thing the lymphatic system does is captures pathogens, captures the antigens of these pathogens, and presents them to the lymph nodes where the T cells and B cells are located, so we can trigger a response. Because what better, the lymph nodes are going to see everything that goes through the body. It's sort of like the kidneys filtering our plasma. You know, the kidneys see everything, the oxygen levels, red cell levels, salt levels, water levels, all that. Well, the lymph nodes are going to see everything coming from the cells, viruses, bacteria, funguses, damaged cells, whatever. And this is going to be where we monitor with our immune system cells, the T cells and B cells in the lymph nodes. And if we detect something foreign, we start producing a response. So that's a very important. That's the other important role. Both of these, you can't diminish the role of fluid recovery and immune response from each other. They're both equally important. We also have supporting cells. Shifting gears again, we have cells that are going to hold the lymphatic system together. the because the it's sort of like well, it's reticular fibers. It's connective tissue, and the connective tissue built into the spleen and into the lymph nodes provides a location for white cells to monitor. But it also gives us structure and shape to these various organs. So the spleen is a squishy ball um, contain that we filter blood into, and we recover uh, uh, worn out red cells here, and we monitor. There's not much to it. It's like imagine like a ball of Jello. It is not much better than the liver as far as its structure. If you've ever seen raw liver, you know how squishy it is. Well, that's sort of like the spleen, but it's uh, these reticular cells that give it um, a fiber-like structure to help hold it together. Not much of a structure. Doing surgery on the liver or the spleen is like trying to stitch together Jello, if you will. So it's challenging. So now the structures of the lymphatic system are designed to do this work for us, to do this monitoring and recovery. The specific structures of the lymphatic system, yes, we have the vessels and the capillaries, and we bring the fluid back, but the organs involved here um, are really designed to filter this plasma by looking for pathogens and triggering some sort of immune response if necessary. So, yes, recovering, because if you don't recover the fluid, you're going to swell up like a balloon and you're going to die. Um, Seems like that's my favorite phrase these days. And then you're going to die, but if you're losing fluid into your tissues, where's that fluid coming from? It's coming from your plasma. And if you reduce the fluid level in your plasma sufficiently, it's not going to end well. The role of the lymphatic vessels is simply to collect this fluid and bring it back to the plasma, but passing it through these various structures like the lymph nodes and the spleen and the tonsils. Uh, these are the lymphatic tissues that we are going to be using for monitoring and activation of the immune response if necessary. So the organs, what we call the lymphatic organs, are going to be the tonsils. Tonsils. Who would have thought that they're part of the lymph system? But they are. So we have the tonsils. We have the thymus gland. Of course, as adults, our thymus gland is pretty small. But when we were children, when we were infants, that thymus gland was very large, and its role was to train T cells to be immunocompetent, to identify foreign antigens and respond to them. Our thymus gland at this point in life doesn't do much for us because it's done its job. We have the spleen sitting right below our stomach on the left-hand side. Blood goes into the spleen. Old red cells are uh, destroyed there, where we recover the iron and we recycle the hemoglobin as we recover the red cells and we lose the globin. We process it through our liver and through our large intestine. Uh, we have what are known as lacteals in the wall of the small intestine. These lacteals, as I've mentioned before, are where we recover fats in our bodies. We have then we have all these lymph nodes. So we have the spleen, we have the tonsils, we have the lacteals, we have the lymph nodes. Uh, we have what are known as Peyer's patches located along the small intestine. These Peyer's patches are lymphatic tissue designed to remove pathogens and bacteria from our small intestine. So we have some very specific uh, organs and organ-like structures designed to keep filtering our plasma and look for pathogens. It isn't just recovering, it isn't just about recovering the fluid, which is very, very important. It's also about looking for pathogens and protecting us. Lymphatic tissue, or as it says here, lymphoid tissue, is where we monitor with lymphocytes, T cells and B cells. It allows it's the location for the T cells and B cells to rapidly surge to, suddenly start, if we detect a pathogen in the spleen or in the tonsils, for example, or in the lymph nodes, we will have a surge in the production of T cells and B cells in response to that pathogen. And so the lymphatic tissue gives the location for these T cells to form. So that's what we mean by proliferation sites. It also, when it gives us a place to monitor all of our lymphatic fluid. We monitor fluid in the lymph nodes. We monitor fluid in the tonsils. The tonsils are designed to become infected. That's what they do. The appendix is often considered a lymphatic vessel because it's designed to become infected also. And so we monitor and we surveil and we respond as necessary. The our tissue is simply, most of it is connective tissue. Um, we keep lots of macrophages nearby, so we have lots of monocytes in these structures, like the lymph nodes. We're going to have the T cells and B cells. We're going to have monocytes because monocytes are going to destroy uh, dead and dying cells and destroy bacteria and destroy viruses. Um, we're going to be able to generate lots of neutrophils because neutrophils respond very quickly to, it's a non-specific response. It's a pathogen. Let's go, kill the bacteria. That's what, neutrophils do. And the lymphocytes uh, will generally, as they circulate through the body, they will continue to return to the lymphatic tissue uh, around, where the connective, where we have these reticular fibers, the connective tissue in the lymph nodes, for example. They will circulate through our body and then come back. They'll circulate through the body and come back to the spleen. They'll come back to the tonsils. They'll come back to the intestines, to the appendix. And so they will constantly be surveilling throughout the body, but spending most of their time in these actual structures. Okay. So we have two types of lymphatic organs. The primary organs, where we have the red cell, where we have the T cells and B cells. This is where they mature. They came from the thymus gland. They came from the bone marrow. The T cells and B cells, both, B cells came from bone marrow. T cells came from B cells matured in the bone marrow. T cells matured in the thymus gland. They became immunocompetent in our first year of life, meaning they could identify foreign antigens. In other words, if it wasn't one of our antigens, then it's foreign. Now, both T cells and B cells will come from the bone marrow. We will, during an infection, when we're triggered, we will produce lots of T cells and lots of B cells from the bone marrow. Remember, they all come from the same stem cell. But it's when we're talking about where they matured, we call them B cells because the B lymphocytes matured in the bone marrow, whereas the T lymphocytes matured in the thymus gland. So now we have a lifetime's worth of T cells and B cells that are circulating through our body, but they, in what we consider relatively low concentrations. Remember that if you do a blood count on your body, you would have, in a cubic millimeter, you'd have 5 million red cells and 5,000 white cells. and that 5,000 white cells is distributed between the neutrophils and the lymphocytes and the monocytes and the eosinophils and the basophils. Um, out of that 5,000, probably 70% are neutrophils, and maybe 65% are neutrophils, 30% are uh, lymphocytes, and then the rest are the monocytes, eosinophils, and basophils. So you don't have a whole lot of circulating T cells or B cells, at least until an infection occurs. The But these are the primary sites are the bone marrow and the thymus gland. That's where they became immunocompetent. The secondary organs, so those are the primary organs. Uh, the primary organs are the bone marrow and the thymus gland. The secondary organs are going to be the lymph nodes, the spleen, what we call as the mucosa associated lymphoid tissue or MALT. Those are going to be the tonsils. It may be the Peyer's patches around the small intestine. It may be anywhere we have lymphatic tissue where we can have white cells, T cells, and B cells monitoring. This is the secondary organs are where we're going to be exposed to our antigens. So the T cells and B cells are exposed to a foreign antigen in the secondary organs. Of all the secondary organs, the most important is the lymph node. The lymph node is the principal organ. There are more lymph nodes than any other secondary organ throughout our body. The lymph nodes are collected together in specific areas like the cervical region, in the neck, the axillary region of the body. We have the inguinal region around the area of the umbilicus and the groin. And so they're clustered, lots and lots of lymph nodes clustered in these areas. And the role, their role is to filter. The role is to filter the uh, plasma. Their role is to filter the plasma or the lymphatic fluid at this point, and monitor. That's the first role is filtration and monitoring. The second role is if we detect a foreign antigen, is to respond to that. So we have filtration and activation. So we filter, we clean up, and we filter. The we filter. We have macrophages in the nodes. We have the monocytes in here. They are going to, you have cell debris, you have a damaged structure, you have a bacteria, anything that's in the lymphatic fluid, because everything collected from the cells is going to end up in the interstitial fluid, which will end up in the lymphatic fluid. We run it through our lymph nodes. We have T cells, B cells, and monocytes located in there. So we have T cells, B cells, and monocytes. Now, if we're just picking up cell debris or bacteria, the monocytes will be activated and remove it. So we're cleaning up the lymph at this point. We're filtering it. We're filtering it through here, and we're cleaning it up with the monocytes. We don't want to have pathogens, or we don't want to have cell debris going into our blood supply. Now, if we have foreign antigens showing up in large numbers, then that's going to activate the immune system. If because the monocytes can't, monocytes are not specific. They're going to anything that's foreign, they're going to destroy it. That's what they do. They're macrophages. If it's a dead cell, if it's uh, fragments of a cell, if it's a bacteria or a virus, they will say it's foreign, I'll destroy it. That's what they do. But if we have infected cells coming in here, if we have uh, cancer cells, if we have viral infected living cells, that will trigger an immune system response. And this is where the T cells and B cells are going to become activated, recognizing the foreign antigen, and then form up to make a specific response to that antigen. Now, that specific response may take 2 weeks if it's a brand new antigen, or it may take 2 minutes if it's one that we've seen, if our bodies have seen before. So, okay, let's take a very short break here uh, on that structure of the lymph node, and then we'll pick up again in about 5 minutes and go on till we're done. So, Okay, we can get started now. And if you haven't uh, joined back in, it'll be okay. This still all be recorded. So a lymph node is shaped a lot like a kidney bean, only a lot smaller. It has a hilus, just like a kidney bean, like a kidney does, and like a um, lung does. It has a outer capsule in here. The the lymph node is divided into compartments. It has a cortex and a medulla. So again, we're seeing the same type of structure that we've seen in the kidney and we'll see this on the spleen, and we've seen it on the adrenal gland where we have a capsule, a cortex, and a medulla. This is what your lymph node looks like. That's not a kidney bean. Um, we have four or more vessels feeding lymph into the lymph node, and only two coming out. So we always have more inflow than we do outflow, and so this maintains a constant pressure in here. It slows down the filtrate, you know, the lymph fluid. It keeps it slow moving inside the node so that we have time to monitor and observe and look for pathogens. Because remember, you're going to have your T cells and B cells in the node along with your monocytes, your macrophages. And so as our lymphatic fluid flows in, it slows down. We have a great deal of time, cell wise anyway, for the T cells and B cells to be monitoring what's coming through. It isn't going through very rapidly, and then the filtered, if you will, and we're not. It's not an indiscriminate filtering. It is a specific filtering looking for pathogens. Then the fluid will leave at the hilum. And so the vessels come in on the cortex on the capsule, the cortex side, and they leave through the hilum. But there's only two leaving the hilum. And so we've had plenty of time for the T cells and B cells and monocytes to do their job. So, and again, here's what a close-up of the capsule looks like. This is the capsule right here. This is the cortex here. We tend to have, it depends on what area of the node you're looking at, is where we're going to be predominantly B cells or T cells. So the cortex is mostly near the surface. You're going to have mostly B cells. B cells will reproduce as needed. B cells, memory cells, we talk about blood cells, even though they have a nucleus, the white blood cells have a nucleus, how most of them get produced, they're constantly being produced in the bone marrow, which is true. But T cells and B cells have a subset known as memory cells. And the memory cells will reproduce through mitosis because they contain the memory of unique pathogens. So we have a library of B cells and T cells, the memory cells of each, that are unique to every pathogen they've ever been exposed to. So the upper cortex has mostly B cells. The deep cortex is mostly T cells. The T cells are in motion. The T cells have been circulating through the blood, through the lymph nodes, through the lymph, throughout the body. And they're coming into the deep cortex now. And they will, of course, if there is any type of pathogen present, they'll start appearing in great numbers. We have cells known as dendritic cells. We'll cover that more in the immune system. The dendritic cells are going to essentially say, hey, there's an antigen. It's a foreign antigen, and that'll help to activate the T cells and B cells, because the T cells and B cells can't be everywhere. to see everything. But so the dendritic cells are like helper cells, not in the sense that they're, well, helper is not a good idea because there is a specific type of cell called a helper T cell, but the dendritic cells are not T cells or B cells. They are white cells that are going to support the T and B. More in that when we get into the immune system. In the medulla, we're going to have T cells and B cells and plasma cells. Now, plasma cells are made from B cells. B cells, when they become stimulated and they're going to respond to a foreign antigen, they will produce what are known as plasma cells. It is the plasma cells that they'll produce in large quantities that make the antibodies. And the antibodies are going to be specific to an antigen. So every time a B cell is exposed to a foreign antigen, whether they've seen it before and have a memory of it, or they've never seen it previously, they're going to produce plasma cells, which will make antibodies. So we are prepared by having plasma cells, a few plasma cells present in the medulla, ready to respond. And that's what they do if there is any reason to, any need to. Now, in the sinuses, we have we have capillaries feeding into the sinuses of the lymph node, and we have a great deal of cross-hatching here with reticular fibers. Remember reticular fibers? They form the framework of the squishy organisms like the spleen and the liver. You know, they give us a framework. Remember back to AP1 lab, way back when we talked about reticular fibers and elastic fibers. Well, reticular fibers give us the framework mechanisms here. The reticular fibers provide a location for the monocytes, the macrophages, to stay in the lymph nodes because you have both the T cells and B cells in here. You've got plasma cells in the medulla. In the sinuses, you have the macrophages because you're still going to see cell debris, dead cells. You're going to see bacteria. You're going to see viruses that the monocytes can take out. You know, your T cells and B cells are going to be responding, particularly when you see, infected cells. Just the bacteria itself, the monocytes will be going after, for example. So, okay, now. So lymph comes in through the afferent vessels, goes into the sinuses, and then goes into, goes through the cortex, through the sinuses, into the medulla, and exits the hilus out with two vessels, if you will. Since there are more vessels coming in than there are leaving, the lymph essentially stagnates in here. It slows way down. The movement slows way down. This gives your B cells and T cells time to observe and monitor, and in the case of the macrophages, to the monocytes, to destroy pathogens, to destroy viruses, bacteria, funguses, to destroy or remove the cell debris or the dead cells. So, and again, this is sort of a simplified animation of what's going on. The lymph, is stagnates in the middle, and that's where you have in your medulla, you're going to have B cells and plasma cells, T cells. Your macrophages are going to be wrapped around all the reticular fibers there, and everybody's working to clean up essentially clean the lymph, take out the foreign substances, destroy the harmful substances, take out the dead cells, take out the dead cell debris. That's one of the big roles of the macrophage. It's not killing a cell, that's the role of the T lymphocyte, but it's taking out the debris that might be infected. It's taking out the debris that we don't need in the blood supply, and that's and helping to clean everything up. Problems. We often see a response to a pathogen. we have swollen glands. Uh, the term for a swollen gland is known as a bubo. It is when a buboes in here. Um, the a gland is infected. It has pathogenic pathogens in there, viruses and or pathogenic infected cells, bacteria, a fungus, and the lymph nodes will do their very best to fight the infection, but they will get overwhelmed. Um, and they will continue to bring in more T cells and B cells and neutrophil and monocytes, and they're going to increase the flow, and they start getting enlarged. That's what we say when we have a swollen gland. We have a lump on the side of our neck, in the cervical region here. The gland is swollen. So who hasn't been to their healthcare provider at some point and they palpate your neck and they say, "Oh, you have some swollen glands here." Sometimes they get filled up with pus. Pus is nothing more than plasma without any of the proteins. The term bubonic plague, you've probably all heard of bubonic plague. Bubonic plague was a bacterial infection carried by fleas on rats. The fleas would bite people and they would pass the infection on, but the fleas would live on rats. And so the Black Death that struck Europe in the Middle Ages and killed a third of the population of Europe at the time was spread by these fleas on rats, because rats were pretty common in those days, and fleas were even more common because fleas lived on the rats. The way you controlled that disease was to get rid of the rats, because the rats were a vector. You couldn't stop the fleas. The fleas were microscopic, but you could stop the rats. Anyway, um, one of the signs of bubonic plague were these tremendously swollen glands. The reason they called it the Black Death is because the person, as they were dying, would get these large black patches in their body. Uh, the um, uh, there were two versions of the plague. There was the bubonic version, and then there was the pneumonia version, where your patient would essentially suffocate, and that's where the black tissue would come from. So they called the thing the Black Death. But the first overt sign were these massively swollen glands, particularly in the cervical region. So when you have a swollen gland, when you have a patient with a swollen gland, it's simply the lymph node lymph nodes trying their very best to fight off the infection. Another problem with lymph nodes is, unfortunately, they become the site of a secondary cancer growth. The primary cancer, the cancer cells are confined to a region of the body, like in the breast, and they haven't spread from the breast. If they metastasize, nearly always the first place they go to are going to be the lymph nodes. And so the lymph nodes, when they have been invaded by cancer cells, will swell up, but they won't hurt. A lymph node infected by a bacteria or a virus will swell and hurt. So you can distinguish between, is it cancer or is it non-cancerous? If it hurts, it's generally, when they're swollen. If the lymph nodes are swollen, uh, and they hurt to swallow, they hurt to touch, then it's nearly always going to be some sort of bacterial or viral infection. If they don't hurt, that's one of the characteristic signs of cancerous growth. So, other organs: the spleen, the thymus gland, the tonsils, and the appendix are also lymphatic organs. Remember, these are the secondary structures now. Um, the They all work to help us. They provide locations for T cells and B cells and macrophages to reside. But the only place where we filter the lymph is going to be the lymph nodes. So everything else here, the spleen, the thymus gland, the tonsils, the appendix, the Peyer's patches, and any other hunks of lymphatic tissue are only helping. They do a great job. They alert us to an infection, but the actual filtering is only done in the lymph nodes. So the lymphoid organs, other than the lymph nodes, we're going to have the thymus gland right on top of the heart. We're going to have the spleen directly below the stomach. We're going to have the appendix lift off of the cecum at the large intestine. We're going to have the Peyer's patches, little patches of lymphatic tissue in the small intestine, particularly on the ileum prior to the junction of the ileocecal valve, so that any bacteria that would migrate out of the large intestine can be uh, monitored, attacked, destroyed from the Peyer's patches. So our spleen is the largest of these organs. It's on the left side of our abdominal cavity. It sits directly below the stomach all the way to the left side of the thoracic cavity. It is very squishy. These structures, all of these supporting structures are made up of reticular fibers. And if you remember what I said about reticular fibers, they hold together the very soft, squishy organs like liver. Like the liver and spleen, these are both very squishy substances. They have very little structural integrity. The reticular fibers give them that. The spleen is fed by the splenic artery and drained by the splenic vein. They have a hilus on the spleen, just like we saw in the kidney, just like we saw on the lymph node, just like we saw in the lung. There is a capsule and a cortex and a medulla on the spleen. So what happens in the spleen? Well, we're not filtering, but if we have detected an infection, or a foreign antigen, we're going to start seeing a massive production of lymphocytes in the spleen. That is lymphocyte proliferation. We're going to have lots of lymphocytes forming in the spleen. We are looking for what we'll do here is we're looking specifically for pathogens. We're looking specifically for pathogens here. That's immune surveillance and response. We are waiting to be triggered by something because that's what it takes. We're not cleaning up anything. That's not what we're doing. We're not cleaning up dead, dying cells or debris or anything like that. We are looking for foreign antigens to trigger the lymphocytes. And so that is immune surveillance. All they do is wait and watch. If an infection spreads into the spleen, then that's going to trigger the response. In fact, most of these other organs, the spleen, the tonsils, the appendix, are designed to become infected and trigger a response. So the other thing the spleen does, boy, that's bad. Cleanses. How about cleans? And of course I can't spell blood either. If you see blood, okay. Anyway, the spleen is going to clean the blood by getting rid of old red cells, worn out red cells. Red cells only last for about 4 months, 120 days on average. And so this is where red cells go to be destroyed. So that's not cleaning the filtrate. Cleaning the filtrate is cleaning the lymphatic fluid. That's what the lymph nodes do. The spleen is not cleaning the lymph. The spleen is cleaning the blood by getting rid of the worn out red cells. The spleen is a site for the T cells and B cells to monitor for infections, for pathogens. And the spleen is where the T cells and B cells can reproduce quickly as needed. So, but it's not cleaning anything except the blood. So we get rid of worn out red cells here in the spleen. This is what our spleen looks like. It's tucked up underneath the stomach, sort of at the end of the pancreas. The pancreas is below the stomach, and the spleen is sort of up against the left side of the abdominal cavity. You can see the splenic artery going in there, and you can't see the splenic vein coming out. And part of the spleen is really sort of pushed up against the diaphragm, but it's all behind the stomach. So it has a capsule, uh, just like a kidney does, just like the adrenal glands do. Uh, there are fibers that extend through the spleen that house they provide a location for the lymphocytes, the T cells and B cells. It also provides a location for the monocytes, but a tremendous number of red cells. This is the primary function of the spleen, is to clean up the blood by taking out old red cells. The spleen contains what is known as a white pulp and red pulp. The white pulp are where we find the lymphocytes. The again, reticular fibers woven through the white pulp here. The T cells and B cells are housed on these reticular fibers. They are looking for foreign pathogens. That's all they do. They're not cleaning anything up. They're not actively and aggressively filtering the blood. That's only what the lymph nodes do. They're looking for foreign pathogens. The red pulp is the section where we take out the red cells. We take out red cells, and this is where we see the macrophages will take out any kind of, as I say, bloodborne pathogens, anything that is infectious through blood-to-blood, blood-to-blood contact, for if you will. So the red pulp, destruction of worn-out red cells, and bloodborne pathogens. So we see there's our capsule. These are the trabeculae here that are dividing up the capsule. The structure, there's the capsule on the surface. The trabeculae divide the capsule up. You have the red pulp here and the white pulp below that. The white pulp is mostly lymphocytes. The red pulp is going to be monocytes and red cells that are being destroyed. So the spleen will capture the iron from the red cells. As we break down the red cells, the macrophages, the monocytes in the spleen, their role is primarily to break down the red cells. We capture the iron from the red cells, and that iron is reused to make new red cells. This is also where before our bone marrow is fully formed, when we are in utero, we're going to use the spleen to make our red cells. And it's also a great place to store our platelets. Remember, our platelets are remember platelet plugs and blood clotting? Well, we store a lot of platelets in anticipation of their use inside the spleen and ready to go in case we have, a platelet response is necessary. So problems with the spleen. The spleen is very, very fragile. It is extremely fragile. It has this thin capsule coating that it's like putting if you had Jello, you had a bowl of Jello and it sat in the refrigerator too long, and the outer layer of the Jello got a little firm. You still have all the squishy Jello underneath, but there's this harder, dried out outer layer. That's like the capsule. Well, you can still stick your finger through the capsule into the Jello. I don't know why you would, but you could. Okay. So this capsule doesn't, imagine the spleen with the same makeup. Spleen has no protection. A blunt force trauma or a penetrating injury to the spleen can damage the spleen, causing it to rupture. Now, conventional wisdom said for years, if a patient has a ruptured spleen, is to remove it because they're going to be bleeding out. Okay, it will be bleeding out, and your patient could bleed out and die. And so, for years, the surgical response was remove the spleen, and the functions of the spleen will be taken over by other parts of the body, and that's fine. However, it's been discovered that if you can control the bleeding and deal with the shock of the blood loss and replace the blood loss, that the spleen will repair itself. And so now the number of splenectomies, from blunt force trauma or from penetrating injuries is way down because the spleen recovers on its own. And so, it is the less invasive procedure. It allows the spleen to heal on its own, and once it heals, it recovers very nicely, and you don't have to deal with the absence of a spleen. Now, if you do lose the spleen, then the bone marrow takes over, the liver takes over. So we have, it was having a spleen removed is it's major surgery, but then the body adapts. The liver can take over the functions of the spleen, and so will the bone marrow. So you're still going to recycle your iron. You're still going to get rid of your your globulin, and that's fine. But by supporting the spleen, controlling the bleeding, replacing the fluids, the spleen will recover on its own in many, many cases. So the number of emergency splenectomies has dropped way down because of that. Again, anything that is less invasive. Remember the old dictum, first, do no harm. Well, the conventional wisdom was doing the right thing for what they knew at the time. Stop, control the bleeding, take out the spleen. And we even find that if you're dealing with a child and the spleen has to be removed, if you have part of the spleen left over, you haven't, that's not damaged, the spleen will regenerate itself, much like a partial liver transplant, where you can donate a portion of your liver to someone else. That liver will regenerate in their body, and yours will regenerate too. So our organs are amazing in their ability to recover in many cases. So, the thymus gland. Okay, so you've seen the spleen. We know what the spleen does. It cleans up our blood by taking out the old red cells. Because red cells, they have no nucleus and they're not going to regenerate. They, 4 months is tops. They're worn out. The ability to carry hemoglobin, carry oxygen is severely compromised. So they have to go. But we're always making more. And essentially, every time we destroy a red cell, we're making a red cell at the same time. Now, the thymus gland, as adults, oh boy, I can't spell. I spelled atrophy with an IE. What was I thinking when I wrote that? Okay, the thymus gland. It looks somewhat like the thyroid. It is bilobed. It secretes hormones, thymosin and thymopoietin, just thymus gland hormones. This is what trains the T cells to become immunocompetent. Lymphocytes either are trained in the bone marrow as B cells, or they go to the thymus gland in our infancy and they become trained as T cells. This is all happening in our first year of life. And so when I say immunocompetent, it means that the T cells are trained to identify all the various antigens on all of our cells in our body. So we recognize them as self, as ours. T cells that cannot make that distinction are destroyed. So we select out for T cells and the T cell lines that are going to recognize us as self. Same thing's happening in the bone marrow for the B cells. They're going to be trained to become immunocompetent for all the antigens in our bodies. If they can't make that distinction, then that line of B cells is destroyed. So all you have are T cells and B cells that are selective for all of our antigens. Now, when we are an infant, our thymus gland is massive. It covers the heart, it covers the middle, it covers the mediastinum in the middle, it spreads out. It is a very large structure, but it shrinks. It shrinks until adolescence when it really isn't, it doesn't grow anymore in adolescence. And then it will atrophy, not atrophy with an I, it will atrophy with a Y. I apologize for that. What was I thinking? Anyway, it will shrink. It will reduce in size to, as an adult. It's a very small structure on our heart now. It's no longer functional. So um, the thymus gland has no direct role in fighting infections. It is part of the lymphatic system um, because it trains up the T cells. It trains them to be immunocompetent, but the thymus gland has no direct role in as an infection fighter. Yes, it provides the T cells that the lymphatic system uses by making them immunocompetent, but it has no infection fighting properties of its own. It doesn't filter lymph. It doesn't do anything, but it does make the T cells. There's a location of our thymus gland. It has a capsule, a cortex, and a medulla, just like a lot of our other organs do. Um, it is largest in our infancy and then shrinks to next to nothing. It atrophies as we, after adolescence, and it's significant, very much reduced in size. So, and that's the role of the thymus gland. All it does is, as if it's not important, all it does is make T cells immunocompetent. That's pretty significant. Scattered throughout our body in our lymphatic system is what we call mucosa associated lymphatic tissue, or MALT, mucous membrane tissue. We have this mucous membrane tissue scattered throughout our body with lymphatic cells in here, so that they can restrict the entry of pathogens coming in our bodies, because we're always you know, uh, breathing in pathogens. We're always eating and drinking, and pathogens come in. Everything we come in contact with is covered with bacteria or viruses, and some are pathogenic and most aren't. And when they find mucous membrane covered with mucus, if you're a pathogenic bacteria, it's ideal, because a pathogenic bacteria loves warm, dark, moist environments. They grow there, they proliferate there. Any bacteria will, not just the pathogenics. So anywhere we have mucous membrane, we have a lot of mucous membrane. Remember, goblet cells are everywhere, in our mouth, in our trachea, in our esophagus, in our digestive system. We have mucus being produced everywhere. And so we have lymphatic tissue. Remember, the role of the lymphatic system isn't just collecting interstitial fluid and turning it into lymphatic fluid. It's also making sure that fluid, that lymphatic fluid, is pathogen free. That's the other half of the lymphatic system. So we have lymphatic tissue designed to provide surveillance of the presence of foreign antigens. So we find this mucus lymphatic tissue in our respiratory system, in our genitals, in our urinary system, anywhere that's exposed to the outside, the urethra, for example, uh, the urethral orifice, the vaginal orifice, the vagina, the uterus, the rectum, the anus, any of these areas here, our mouth, our esophagus, our nasal cavity. So we're going to have clusters of this lymphatic tissue, this mucosa-associated lymphatic tissue scattered throughout, designed to protect us from the entry of foreign antigens. And we see them in the tonsils. The tonsils are what we call, fall into the category of MALT. Tonsils are designed to be sacrificial. They're designed to become infected. So we have tonsils, we have Peyer's patches, and we have the appendix. All are designed to become infected to alert the immune system that we have a problem. So our tonsils, we all, well, you either have them or you don't, depending on your age. You may have had them taken out as a child. You may not have had them taken out as a child. You may have had them taken out as an adult, or you may still have them as an adult. The There are 4 sets of tonsils. They form a ring around the opening of the pharynx. Um, they look just like a bump in there. You can see them. You really don't notice them until they become infected. Now, the palatine tonsils are very large tonsils on either side of the uvula. The uvula, of course, is the little dangly thing back there at the back of the oral cavity, designed to, when we swallow, to flip up and close off the nasopharynx, so we don't, we don't shoot fluid or food up into our nose when we swallow. So the palatine tonsils are the largest. We have the lingual tonsils. They are found at the base of the tongue. The pharyngeal tonsils, we call them adenoids when they're infected. The rest of the time, they're the pharyngeal tonsils. They are in the back wall of the nasal cavity, just on either side of the opening for the auditory canal, not well, the esophageal, the pharyngotympanic canal, the one that equalizes air pressure. We used to call it the eustachian tube. Okay. So they're right next to that opening for that canal, which provides, the canal, of course, provides this great passageway for bacteria, into the ears. That's where ear infections spread from the nasal infection in children. So anyway, um, the pharyngeal tunnels are in the back wall of the nasal cavity. They're adenoids when they become infected. And then, of course, we have the tubal tonsils, which are directly below the pharyngeal tonsils, that are protecting the auditory tubes themselves. When infections spread, it's because these tonsils have gotten overwhelmed by the bacteria that are present. So we have around the oral cavity, we have the large ones are the palatines. This is a palatine tonsil. If you look at the picture at the bottom, you see the uvula, you see the large palatine tonsils here. These are probably infected, but given the fact that there are what look like ulcers and blisters on here and a lot of white material indicative of an infection. So generally they're not quite that large. So the lingual tonsils are at the base of the tongue. They're all the way near the back of the tongue. And of course, the pharyngeal tonsils then are at the bottom back wall of the nasal cavity. So we would see here, right below the nose, you would have the pharyngeals, the palatine, and then the lingual. And of course, you also have the tubals, which you're going to find right next to the auditory canal here. So the whole purpose of our tonsils is to trap pathogens. Trap pathogens and remove them. When we breathe air in, or we eat food, or take in fluids, they're going to be covered with bacteria. Everything is covered with bacteria. Everything we eat and drink has bacteria present. It's only the amount of bacteria, the amount of the pathogen present determines whether or not we're going to be affected. You can eat food that's been has bacteria on it, and you're not going to become symptomatic. You open your refrigerator and you pull out a container. It looks very sketchy. It's been there for quite a while, and you open it, and it looks okay and tastes okay. it may or may not have enough bacteria to make you sick, so you eat some of it and you don't become symptomatic. Well, it has to do with the number of pathogens present there. You can eat, you could be at a potluck dinner or a buffet, and you're the one person that gets the um, serving that has sufficient bacteria uh, on it to make you ill. The whole idea, we cook our food, obviously we don't like to eat it raw, some things anyway. We cook the food to make it palatable. We cook the food to kill bacteria. Bacteria starts coming back as soon as we bring the food out. Uh, it's just how much bacteria can we knock down? Refrigeration is designed to simply reduce the growth of bacteria. You eat something, you cook something, put it, you put it in the refrigerator, it cools down, and that cooler temperature, 37 degrees or whatever you keep the fridge at, is going to reduce the growth of bacteria, but they're still going to grow. They're still going to grow, and so eventually, if it's pathogenic bacteria, and you eat it, 2 weeks later, uh, you have a greater chance of becoming infected. So anyway, you know, don't let me digress like that. The tonsils are designed to capture bacteria that are found in the things that we eat and drink and the air we breathe. Designed to capture the bacteria and destroy it. They're lymphatic tissue. Um, they have lymphocytes embedded in the membranes of the tonsils. Um, But what they do to guarantee that they can get a response is they have what are called crypts. They have these depressions, these invaginations in the lining of the tonsil. So it's like a pit that the bacteria, the pathogen can uh, essentially migrate into and find a warm, dark, moist environment to grow. Or, you know, viruses don't care. Viruses are not alive. They will just reproduce themselves when they find a host cell. Um, the so the pathogen will grow in this environment, and that's the trigger. Um, the idea is to trap the bacteria, trap the pathogen in the crypt, and then destroy it with the lymphocytes, or with the uh, if the a cell has died, then monocytes will take out the debris. The What we want to see is that we essentially it's a very risky game for the tonsils. Tonsils are going to lure in the pathogens and trap them in these crypts and then destroy them. And as long as the tonsil isn't overwhelmed, the tonsil wins. But if there's a tremendous influx of pathogens, you suck in a lot of air containing bacteria or a virus. Someone you someone has a highly infectious disease, and you drink after them, or uh, you exchange spit, as they say. A person with mononucleosis who is highly contagious shares a little spit with you, and that virus is transferred in, and it moves right away, into the tonsils, and it overwhelms the tonsils. The It is a tricky procedure for the tonsil. Um, Particularly, uh, tonsils can't do a whole lot to help us with viruses, but they can do a really good job with bacteria. Bacteria will grow in here. The risk is they can overwhelm the tonsil. However, the idea is that this pathogen, why are the tonsils doing this? Why are we letting ourselves become sick through our tonsils? Well, the idea is that we can, if it's a brand new antigen that we've never seen before, then we will mount an immune response to it. And now we'll have the memory of that foreign antigen so that we'll never get sick from it again. Because usually, once we're exposed to a pathogen and we generate antibodies, we keep a memory of that pathogen. so that the next time we're exposed to it, we don't take 2 weeks to produce antibodies. We produce a million antibodies in about 2 hours. So we're we should never be symptomatic to that particular pathogen again, theoretically, you know, or a virus. People that that didn't get a vaccination for chickenpox, for example, and developed chickenpox, they have their immune system has antibodies to the chickenpox virus, and they have memory cells that remember what that virus is. So when they are exposed to that antigen again, they have a rapid response. So instead of taking 10 days to get over chickenpox, you're not even symptomatic. And so what the game that the tonsils are playing is to trap the bacteria, trap the pathogen, alert the immune system, produce a response, so that the next time we're not we don't have symptoms, we're not ill. So sometimes though our tonsils get really overwhelmed and they become heavily inflamed and engorged, and it's very painful. It happens. So these are the crypts I was talking about. These are these gaps deep down inside here. Uh, that is how we are designed to have these long, deep structures here, sort of like the pits in the gastric pits in the stomach. Uh, we are we are designed to capture these pathogens. You know, there's our pharyngeal tonsil up here, our palatine tonsil right there, that large one, then is the lingual tonsil, and the tubal tonsil is right there. So, yeah. Now these are the palatine tonsils. We're looking directly down. Now these tonsils are not infected, they're just overly big, but you can see the tonsils on either side of the uvula there. They are normal. This individual is, this is a normal, examination. I want to use the tongue depressor and you say, ah, you know, uh, a lot of that is to measure your gag reflex as opposed to anything else. So here we see there are the lingual tonsils there. This is a palatine tonsil is back here. Here we see a palatine tonsil, the uvula, and the other palatine tonsil, but you can just see where the lingual tonsils are located right there. These are all this may or may not be infected. Uh, Here we go. Here are some seriously inflamed palatine tonsils right here. A lot of ulceration, a lot of swelling, difficulty in eating and swallowing, probably difficulty in breathing, because if these are swollen, the adenoids are probably swollen too. Here we see ulceration on the tonsils. We see the uvula is swollen. So this is, this probably hurts a lot. Your patient with this is probably very uncomfortable, very symptomatic. So, and even more, look at the ulcerations here. We're practically touching the uvula here and over here. A lot of ulceration taking place in here. So a lot of swelling. Uh, again, the consequences are it's difficulty to swallow, it's difficult to breathe. If the pharyngeal tonsils are swollen, then your patient's likely breathing through their mouth. Uh, Eating is difficult, swallowing is difficult. It hurts, and when it hurts to do something, we try to avoid it. So now there are the adenoids right there. You can see both on the drawing and on the X-ray. And they're designed to protect us from pathogens that we inhale through our nose, as opposed to what comes in through what we eat and drink. Whether we're breathing through our mouth or nose, it doesn't matter. We're still going to try to trap everything in our tonsils. Now, the Peyer's patches, they function similar to the tonsils. We have them in the small intestine. Uh, they have the same type of arrangement. They have a crypt-like structure. They are designed to become infected and to destroy bacteria. They're designed to alert the immune system, and so they can produce memory cells. You know, they can have memory B cells, memory T cells to give us this lifetime of, of immunity after an infection. So uh, their primary role is to destroy bacteria that may migrate, particularly from the large intestine. The these Peyer's patches are located very near the ileocecal valve to prevent the migration of bacteria from the colon. You know, because the ileocecal valve, you're essentially the ileum is joining the cecum, and you know we have all this bacteria inside the large intestine trying to process the indigestible fiber, you know, helping us to produce vitamin K and some of the B vitamins, helping us. You know, we're trying to get water out of there one last time, and you know, if we get that bacteria, you know, if there's pathogenic bacteria in our gut, it's you know, or even if it's healthy bacteria, we don't want it migrating into the small intestine. So we use the Peyer's patches to protect us. And they, again, their role is to generate, you know, if they fight infection, their role is also to destroy, uh, to generate memory. So, and this is what they look like. It's like a little bulge on the ileum here. These dark brown spots here are the Peyer's patches. These are lymphatic tissue, uh, and they're going to be very, like I said, very very close to the ileocecal valve of the small intestine where it joins the cecum, because bacteria can migrate out of the large intestine. So. And again, they have a very similar arrangement to their structure, not unlike a tonsil. You know, the idea is that the bacteria get trapped down in these crypts here, where it gives it a chance to grow. But then our response is to kill the bacteria or alert the immune system to the infection. So, and then we come to the appendix. There's our appendix. It descends down off of the cecum. The cecum is the pouch. Here's the ileocecal valve right here. And our Peyer's patch would be located just below the curve on the ileum as we head back towards the ileum proper. But there is our appendix. And the appendix is also designed to be sacrificial. Now, besides that, there's other properties for the appendix. The appendix is not a vestigial organ. You know, it's not a useless organ. Its role is to protect us and to alert our immune system. It also is designed as a storehouse of healthy bacteria so that when we take antibiotics or something, or we have you know, some sort of health issue where all the bacteria in our colon is destroyed, we can repopulate with our own healthy, as we say, indigenous bacteria, our own bacteria. So um, the appendix acts like Peyer's patches. It acts like tonsils. It will destroy bacteria. It will generate memory. Those are the two key things it does, just like the Peyer's patches, and just like in many ways, just like the tonsils do. We don't want the bacteria coming out of the colon that's found in the colon to breach the wall of the intestine. You know, we don't want, like the Peyer's patches, don't want bacteria coming from the cecum to break out of the intestine into the abdominal cavity. The same thing is true here. We want to protect the abdomen so that the large intestine can't infect the abdominal cavity. And more importantly, we want to generate memory cells. So what does the appendix do for us? Well, We used to say for years and years that it was a vestigial organ, it didn't do anything. And that has changed in the past 10 years. The appendix is a reservoir, functions as a reservoir of our own healthy bacteria. Uh, if you have a patient that has had cholera, where they've had a tremendous amount of passage of waste products, with cholera, you have bouts of diarrhea. It's essentially watery diarrhea, and you're washing out the inside of the colon, because and you are then prone to more infection. Well, if you or dysentery. Dysentery is another illness that causes massive amounts of diarrhea and destroys the natural population of bacteria in the gut. The appendix serves as a reservoir of healthy bacteria that will repopulate the large intestine. And so we get our indigenous bacteria back pretty fast once we get over the illness. Or perhaps you have a patient that's taken a course of antibiotics, 10 days of amoxicillin or something like that. That's going to kill the healthy bacteria in the colon. Well, again, they'll be repopulated by what was in the appendix. The appendix then functions as a safe house for our own bacteria. It helps to trigger B cell responses and T cell responses. It helps us to trigger memory so that we generate memory cells. From an infection, our appendix is inflamed. It doesn't always mean the removal of the appendix. Many times the appendix can be treated with antibiotics. The role of the appendix then is to, when we're infected, when it's infected, is to trigger an immune response. So if it can't process it itself, is to trigger an immune response so that we get memory, so that we don't become symptomatic the next time we're exposed to that same pathogen. That's what memory is all about. We don't want to have, we don't want to spend 14 days getting over the flu every time we're exposed to the flu virus, that because that would be very detrimental to our health. If we're going to get sick, we're going to be symptomatic from the flu. We want to, if we get it, we want to get over it, and we want to be able to go on and not get it again. And that's happens because we retain the memory of those unique pathogens, the antigens. And that's what the appendix is trying to do for us also. So now, what causes appendicitis? Well, the appendix is blocked. It's often blocked. Fecal matter blocks the appendix. Remember, the appendix hangs down right here. It's open here. Fecal matter can block the opening into the appendix. Something, maybe a polyp can grow there. Maybe even a tumor can be growing there. Maybe it's swelling. Maybe we have inflammation taking place there. But what will happen is the appendix is blocked, and that can cause an infection. No, that's sort of difficult to treat with antibiotics, and sometimes you'd still have to remove the appendix. And that's a decision that your healthcare provider makes. You have an inflamed appendix, and it's not going to respond to antibiotics, and so you remove it. We can compensate. We have other tissues that can compensate for the appendix. But the appendix is doing a very important role, though, in protecting our own immune system, protecting our bacteria that we need. So, and that is the end of the lymphatic system. That sort of snuck up on us there. So one thing that if nothing else, you can now remember that the appendix is not, as they say, a vestigial organ. The appendix is a very necessary organ for us. So if you have any questions on this, feel free to shoot me an email and I'll get back to you. Tomorrow we will go through the immune system and hopefully a lot of what I said today about immunological response will make more sense because tomorrow we'll talk about the memory cells, B cells and T cells, and their ability to generate a memory that lasts a lifetime for us. So that if you had, if you had chickenpox as a child, you never get it again. Not because you've never been exposed to chickenpox virus, but because you are no longer you provide an immediate response. So, okay, I'm going to end this, and I will see you all tomorrow at um, 9 o'clock. Thanks, Christine, and I'll talk to you tomorrow.